Good morning. So today we are continuing with the diuretics. So first we'll discuss about the mechanism of action of carbonic anhydrous inhibitor. Now acetazolamide and other carbonic anhydrous inhibitor, they are the most often used as their pharmacological activity other than the diuretic effect, because they are the weak diuretics. They are the weak diuretics and they are not efficacious like that of the thiazide diuretics or the Loeb's diuretics. Now here this is the proximal convoluted tubular cell. Proximal convoluted tubular cell. Here what we can see that into the lumen area. If we see about the lumen area, here the Na plus H2CO3 it is there. Again you can say that they are present, so sodium it will be absorbed as a, here we can find a antipode, so sodium it will be absorbed and H plus it will be going towards the urine or the lumen. So sodium is entering and that is the hydrogen it is going. So here HCO3 and H plus, so they are forming the H2CO3. Let H2CO3. Now this H2CO3 in presence of the carbonic anhydrous, in presence of the carbonic anhydrous, it will break down into H2O plus CO2. H2O and CO2. Now they will enter into the proximal convoluted tubule. They will enter into the proximal convoluted tubule and again they will form the H2CO3. H2CO3, and again here who is important? Here the carbonic anhydrous, it is important. Now H2CO3 again you can say that it will be break down into H plus and CO3 minus. Now this H3 again it will go into the tubular, where the HCO3 it is going to the basolateral area, that means into the blood. Sodium, and through the sodium and potassium ATPs there is the exchange of the sodium and potassium takes place, it is there, and chloride exchange it is through the base. Now this particular type of the drug acetazolamides, they are going to inhibit this carbonic anhydrous enzyme. So they are inhibiting the carbonic anhydrous enzyme. So if this enzyme is inhibited, what will happen? There will be no formation of H2CO3. Even this particular breakdown of H2CO3 into water and carbon dioxide, it will be not there, so it will not able to enter. So ultimately what is happening? Ultimately they are inhibiting the reabsorption. Clear? Say here H2CO3 it will be reabsorbed through by changing its nature, and then it will be you can say that reabsorbed from the proximal convoluted tubule. So they are inhibiting the reabsorption of HCO3 ions. Clear? HCO3 ion. Clear? So you can say that in this particular phenomena, almost 66% of the filtered Na and 85% of the NaHCO3 normally reabsorbed into the proximal tubule. Now carbonic anhydrous, it is responsible for the loss of NH2 NaHCO3. NaHCO3. NaHCO3, they are responsible for the loss. So hypocalamic metabolic acidosis it is there, and tolerance develop after 2 to 3 days. So by inhibiting this, they are increasing the water excretion. But again it is a weak diuretics. It is considered as a weak diuretics. Next is potassium sparing diuretics. Potassium sparing diuretics. Now in case of the potassium sparing diuretics, see here mainly we are going to discuss about the two category of the drug. One is the aldosterone. Aldosterone receptor antagonist. Now what will happen? This is the collecting tubular cell. In collecting tubular cell, here into the lumen area there is a high sodium is there. Now this you can say that sodium it will enter into the collecting tubule cell through a membrane epithelial sodium channel. Clear? Now what will happen? This aldosterone, when the aldosterone it will be synthesized, the aldosterone it will be act on the aldosterone receptor. AR means aldosterone receptor. They are going to act on the aldosterone receptor. Now what after binding to the aldosterone receptor, they are increasing the expression of this sodium channel. They are increasing the expression of this sodium channel. So if this sodium channel, it will be, you can say that expression it will be there, so more sodium it will enter into the collecting duct. The more sodium from the lumen area, it will enter into the collecting duct. Similarly, when the aldosterone bind to the aldosterone receptor, it will increase the you can say that reabsorption of the water through by, you can say that, initiating the sodium potassium ATPase. Sodium is reabsorbed and potassium is entering into the convoluted collecting tubular cell, and then it is going into the urine. Urine. So calcium can go through the pores. It can be go. Now, so what that is aldosterone receptor, clear, after binding with the aldosterone, they are increasing the sodium channel expression, as well as they are you can say that they are also increasing the sodium reabsorption. Almost 2 to 5% of the filtered NA normally reabsorbed into the collecting duct. So through this collecting duct also sodium it is reabsorbed, but only 2 to 3%. Now, whenever we are giving this spironolactone type of the drug, that is the aldosterone receptor antagonist, what will happen? They will go and they will block this aldosterone receptor. They are going to block the aldosterone receptor. So, if this receptor is blocked, there is the decreased expression of the sodium channel into the luminal membrane epithelial cell, and also they are, you can say that, inhibiting the reabsorption of the sodium. So as a result, sodium reabsorption is inhibited and water excretion it is increased. In case of the drug which you can say that like amyloid type of the drug, already if you remember that already what we have discussed, now this type of the drug, that means those directly blocking the luminal membrane epithelial sodium channel, luminal membrane epithelial channel, they directly go and directly block this sodium channel. Now if there is this channel is blocked, what will happen? No sodium it will be there, or the very less sodium it will be available to reabsorb. That means they are inhibiting the reabsorb, clear, they are inhibiting the reabsorb by blocking the sodium channel. So more sodium it will be excreted, more water it will be excreted. Now as it is only 5 to 10% of the sodium reabsorbed via this process, that's why you can say that they are considered as a weak diuretics, clear, weak diuretic, and you can say that it is responsible for the loss of sodium and water. So this is about the mechanism of action of potassium sparing diuretics. Next is osmotic diuretics. Now in case of the osmotic diuretics, if we see about their mechanism of action, again they are the urine or the lumen and blood. So water solute and osmosis. See, already we have discussed about the osmosis in details in our very first class of the diuretic. So H2O mannitol it will be there, mannitol it will be there. So it is a mannitol, it is a non-absorbable solute. It's filtered by the glomerulus and cannot be reabsorbed, causing the water retained into the region of the proximal tubule and descending loop of Henry. It can prevent the normal absorption of the water in this region. Now what will happen? Mannitol it will be there, so it is considered as a solute. So more water it will be transported through the towards the lumen. Clear, more water it will be lumen, because due to the osmosis. As a result, you can say that there is a loss of water. Now you can say that here may not be you can say risk of the sodium. You can say that they do not have a directly effect on the sodium channel, but through the osmosis they are going to act. So this is the mechanism of action of osmotic diuretics.